Good morning, America. Good afternoon, Europe, Africa, and good evening, Asia and Australasia. Welcome back to the ISRT Facebook Live. And today is a very special day for us. This is the first year anniversary of the ISRT webinar. And also, this is a special event for our webinar because this is going to be also the first time that we feature nuclear medicine. And the topic for today is the role of the nuclear medicine technologist or nuclear medicine radiographer in patient safety and quality using advanced nuclear medicine technology. Before we go ahead with our program for today, I would like to have our president, Donna Newman, to have a word just to celebrate our first year anniversary of the Facebook Live. Donna.
Good morning, good afternoon, good evening, everyone. I can't thank you enough for joining us today. This idea to network and get best practice out there by connecting with our member societies and our experts around the world. We never could have dreamed that it would have turned into such a popular program. And we can't thank our members that have been our experts enough for contributing their best practice knowledge with people around the world. I thank you for doing that and appreciate each and every one of you that have tuned in and celebrated with us today. We hope that today's program will give you good information on how to work within the cutting edge technology of nuclear medicine and how to ensure that yourself and your patients have a safe practice when you are working every day. I thank our guests that came today to be experts for us and share their knowledge. And I look forward to the panel discussion to talking about the best practice in nuclear medicine. Thank you all for joining us today. And I'll turn it back over to you, Napapong, to begin our program.
Thank you, Donna. And I would like to introduce our four speakers one by one, and then they will give a presentation. And after our presentation, we will have the Q&A session with the panelists. We have two panelists for today with Donna Newman, the president, and also we have our CEO with us, Dimitri Katsifarakis. The first speaker is Patrick Wojtlak. He's from the US. He's a supervisor in nuclear medicine, PET-CT, PET-MR, University Hospital of Cleveland. And the topic that Patrick will present today is the role of the nuclear medicine technologists in patient safety and quality in PET-MR. Please welcome Patrick Wojtlak.
Hello, everyone. My name is Patrick Wojtlak, and I work at University Hospitals of Cleveland. I'm going to do a presentation on the role of a nuclear medicine technologist in patient safety and in quality in PET-MRI. Let me share my screen right now with you. So molecular imaging is growing. As we know, one of this is the bread and butter of one of nuclear medicine's biggest shining star is molecular imaging, and multiple modality is even more growing because it is a hybrid imaging. And from this quote in 2009, you can see that they're saying that hybrid technology, which would in nuclear medicine could be PET-CT, PET-MRI, or SPECT-CT, is growing because of this functional imaging, which we do in nuclear med with the anatomical localization of the combined scan. PET for decades has been a mainstay for the practice of nuclear medicine. When it first started, it was PET only, and there was an attenuation source, and that was what we were using for correcting. But now, as we know, that we're bringing anatomical imaging into the PET world, and it grew so vastly. PET-CT changed how nuclear medicine departments were running, and now there's PET-MRI. So when you combine a CT or an MR to a PET scanner, you get this amazing anatomical imaging, and it just helps for proving better outcome and giving better results for the patient. The growth of this modality in past decades, as I said before, PET-CT has been growing. It's just because it improves diagnostic accuracy all the time. And that is something that is so important because you can overlay the PET with whatever anatomical, which is the CT. And this is what's great. It makes it easy. You can localize and you get quick answers for patients and for the ordering physicians. And there's large volumes of these scans being done. Where I work, we do about 50 a day, every single day. And the growth of PET-MR, can it be the same? Probably. It should be able to, but it's going to have some limitations. So there is it might not be the exact progression, but how can it grow? The biggest question is that any new rapidly emerging modality, you need to understand the principles. That's very, very important. PET-MRI is no different. There's many, many concerns. There's quality control issues that we're going to go over, potential pitfalls, which is MR safety and limitation. But these are things that there is lots of learning that you need to understand if you're going to get this. But what can PET-MRI bring? PET-MRI can bring is a true molecular imaging, has less radiation exposure because there is no radiation exposure, but it does bring with it a big safety issue, and that's MR safety. What is MR safety? It's MR safety for the patient. The person you're going to be scanning, they need to be safe. So you need to be able to look and find out, do they have pacemakers or do they have aneurysm clippings? All these things that are coming with patients who are sick, you need to understand this. You need to know what this is about. And you need to know if they have all these, because you cannot bring them into the MR field. The other thing that you might not think about is the personnel that work around this thing. And it's not just your patient in the PET MRI techs, it's all the healthcare professionals that work with us. Anybody, like a family member that's there, security officers, housekeeping, firefighters when there's emergencies, police when there's emergencies, anyone who encounters the MR field is always under concern. The reason is because the magnet's always on. It never turns off. It is always on. And as you can see with these pictures, these are beds, these are cleaning equipment, these are chairs. So the magnet is always on. You need image synergy. So what that really means to us is you have to understand both modalities, the operation and the technical side. Everyone needs to understand there is going to be some different types of reconstruction, which is what's going to be done with PET-MRI. You need dual technologists. You need an MR tech and a nuke med tech, or like where I work, our technologists are both certified in nuclear medicine and they're certified in MRI. You have to re-educate everyone. Everyone needs to be educated in MR safety, and it's a collaboration. It is two departments. We are part of radiology, but there is an MR department and there is also a nuke med department, so they do have to work together. Another really important thing is just to look at the two different strengths. So how is PET MR going to be comparative to PET CT? Well, the CT and PET CT has a great strength that it is automatically an attenuation map. Very, very important. It has great anatomical information. You get a quick scan. The weakness is always in CT is the soft tissue contrast resolution. It's not very good. It has more radiation than an MR because MR has none. And it is, a lot of times these PET CTs are done without diagnostic contrast on board, IV or oral. And a lot of times it's not done with breath hold. The MR, what is the strength in the MR and PET-MR? Well, it has no radiation. It is superb soft tissue contrast. It's great functional imaging, but its weakness, there's a lot of them it comes into is because now you have to put a PET scanner into an MRI field. So now you have to develop this machine from the ground up. Everything from detectors to coils, everything needs to have shielding, all these things that need to be run because you're going to run electronics in a magnetic field. The attenuation map is just not a density map. It is not a CT map. It's just based off of hydrogen and tissue. And then the MRAC, you're always going to have some sort of artifacts from that. But there are some great opportunities for this. You know, spectroscopy, new imaging agents, less CT radiation that you're going to be doing on all these PET CTs. So the less ionizing radiation is better. But then also too, you can look past just oncology. You can use neurology. You can look at cardiac, anything you can look at, because this is the opportunities. But there is a challenge. Again, it's the technical challenges that come with this scanner can be very difficult. The environment we live right now is this is high technology, as in high price technology, and how much of a different of an outcome do you get? In the United States, what type of reimbursement that we have to have for these type of scans? The study is just the same as a PET scan is pricing wise in insurance, but the scanner itself is much more expensive. A PET MRI is about $5 million to $8 million. The length of the scan, it's also a problem. MR is much longer. There's multiple exams. There's no such thing as whole body MR imaging. You're getting an MR of your pancreas, your kidneys, your liver. That is what they're looking at. So what we do in PET is whole body, but they don't do. And then, just the intrinsic complications that come through here. The MR is a complex scan. Who's going to actually read these things? Is it a dual read? Is it a single read? But there needs to be some collaboration with everyone. And then the hardware is the biggest thing, because you are also taking all this material from a PET scanner and put it in a magnetic field. You're running electronics in there, so you have to have shielding around everything that goes in there. How are you going to run it? How is it going to work in that field? And then the attenuation correction is what I went through before. It's going to have its limitations. And so with all those kind of things, it's just going to come, and then there's going to be artifacts that you're going to see, which we will go through. So the attenuation correction. CT scan is what we're used to, PET CT. The CT has a true attenuation map. MR does not have one. It's segmented so this is what we've done on a patient. So this is a CT, a low dose CT of a patient with lung cancer. You can see the lung mass. You convert this into an attenuation map. You can still see the lung mass. You can still see everything. CT looks beautiful. For the scanner that we work, we use a T1 weighted for the attenuation map. And now if you look at the same patient, that lesion in the lung does not show up. So it is different, because you're making this up. You're not truly getting like a CT. So these are just the two maps, side by side. If you can see the lesion up there. You can see the lungs. For us, it looks the same. It doesn't look that much of a difference. When we did our reconstructions, the SUV comparisons are fairly close. They're not that much of a difference, about 10% off, but that's not that bad. But the image quality looks okay. But, those are just some of the things that you're going to have to work with. So if you're very used to always looking at an SUV, you're going to have these problems. Another challenges that we're going to go through is for motion, pulsation artifacts, truncation, wraparound, and metal. So pulsation artifact. That just means that when the MRI goes from left to right or the right to left, that's what the sequence does. And when it goes from there, it can actually create, this is a patient that we created a lesion accidentally on the patient. You can see it in the MR, you cannot see it on the PET. So we know it's not true, but if you were going to look at this, you would say this is an artifact and this is a problem. Metal artifacts, if you look where the yellow arrow is, there is just a black spot. That's what metal shows up as. And look at the lungs. The lung is black also. So it is reading metal and air as the same density, which we know they do not have the same attenuation. Here again is a patient with shoulders, with reconstructed shoulders. You can see this where the yellow is. But then if you look at this, just look at the attenuation map. It's thinking it's air, which is what we expected. But look, at one side's white and one side's gray. So it's not even understanding the differences in the two mapping. And these can all cause problems. Another thing is surface coils. Everything that comes into there, now you're going to have an attenuation map of everything that you're using. So every coil that you use, you're going to have an attenuation map. And you need surface coils because the coils are what help in MRI, is what you image with. So they have to be put around the patient, but you do have to have maps of these. And these are just showing you some examples of maps. So you have to have a map of the table because that's in there. All the different hardware that comes in there, from the cardiac to the breast to the spine coil, all these different coils, you have to have maps. And the images are fine as it comes across. You can see you have a good image, a brain image, but this is what it would look like with the attenuation map. You have all that stuff you're seeing all that, and you have to be able to see that. You have to know what it is, and you have to be able to, create an attenuation map for it. So what you really want is a better sequence. This is what we do now. These are better sequences. These are Dixons. And look at this. This really looks like a part of a human being. You might be able to read this better as a physician than some of the other things. But this is what you're looking at. You want to develop better sequences. Because if patient is, you can use this as better localization, and hopefully you can use this as better localization, but also better attenuation map. Another thing that's really, really concerning when it comes down to this is MR safety. Those are the biggest things that you have to worry about. MR safety is one of the biggest things you will look at. You have to look at the zones of where the MR is, where patient screening is, and what the non-personnel are going to be, non-MR personnel are coming in emergencies. So in zone 1, you're going to have be able to have, the least restrictive area. That's just the basic areas like public areas. That's zone 1. That's the waiting room. That's the check-in areas. And zone 2 are the changing areas and the storage areas and cleaning areas. But 3 and 4 are the two that you have to concern you about. 3 is the controlled by the personnel. There needs to be barriers set up. For us, we have like plastic chains that we have on certain areas so that patients and people can't just walk through. They would have to move this plastic chain to get into the MR door. And that is for zone 3. And then zone 4 is the scanner room itself, and that is the most restrictive. And so what you have to do is also be screening all these patients. So you have to have a very good questionnaire. You have to look up patient information. And while you're looking up this patient information, we do it 4 days ahead of time, 5 days ahead of time. You have to look for implants, clips. And then even after you filled out this whole questionnaire for this patient, when the patient comes in the room, the technologist has to do the same thing again. They have to ask all the same questions again to verify everything that they got as information was correct. They have to visually inspect the patient themselves. And then you have to have a metal detector. We have a wand metal detector. Some people have an actual metal detector that people walk through, but this is what we can do to be safe, to make sure that every patient is getting no harm when they're having these type of scans. Again, the non-MR personnel, you have to screen anybody, anyone who walks through. Somebody walks in from facilities and they want to come in here and they're coming into zone 3, you're going to have to ask them questions. You have to make sure they understand what's going on, because it is an MR field. There is a magnetic field that is out here, and you need to know this. And they just cannot just walk in. So you have to ask all the questions, just like we did before on other patients. Emergencies happen all the time. All personnel must be trained. So if it's a real emergency with a patient emergency, then we need to pull these patients out of the PET MR scanner. We need to bring in the MR safe cart. We need to pull this patient out of these zone 4 and bring them into zone 2. But like even the same thing, if there's a leak or anything, all those things need to be known. So facilities and people cannot just go into this room by itself without knowing what's going on. Again, this was the slide that I used at the beginning of the talk. And this is another thing you need to know, that MR safety and for the personnel, who are all these people that are coming in? There's so many more people than just the technologists from the nuclear medicine department that are there. And this, again, is what we're looking at. The security, housekeeping, anyone, when you're cleaning an area, how are they getting in here? What is going to, you have to have policies, you have to have things, procedures written down to understand what we're going to be going. Because again, the magnetic field is always on and it can affect everyone. But PET MRI has great opportunities. It's just you have to develop some manageable protocols, because MR is long scans and there's multiple MR scans. Billing, making sure that you get paid for everything that we do is the most important thing. Buy-in from departments, that is a very important thing. You need to have people that are going to be, who are your referring physicians and how do you get them moving in? And then how are you going to manage the readings? But like for us, we get the buy-in from radiation therapy, from oncologists, from surgeons. We make sure that they understand what's going on and this scanner is available and what it can do for them. On the horizon, you're going to see new sequences, faster MRI sequences, better MRI sequences, and that will just, hopefully, it will never compete with PET CT, never compete with the speed of a PET CT, but there are some patients that would probably be better for them to have a PET MRI than a PET CT. And so for my conclusions is you just have to have knowledgeable technologists, have to understand what's going on with artifacts and all the technical considerations of a PET MRI. You have to try to be able to minimize these artifacts. If you're going to have the artifact, how are you going to work around those artifacts just to get the best possible imaging. MRI safety training, I will say it over and over. It is a very, very important. That MR safe is the most important thing you will have to do with this. Again, the synergy of the imaging is important. Everyone needs to understand the modalities. The operators need to understand everything from operational parts to the technical part. Understand the reconstructions that are different. You need dual technologists if possible. You don't have to do what we do. We have technologists that have both, but if you can, it would be great. But if you have one of each, that's even better. Re-education. Education is all I'm going to say. Education of the people about MR, because MR safety is something that you just don't think about in nuclear medicine. And now you're bringing a whole different modality into our field. So you have to know that. The collaboration from both departments, it is so important. Thanks so much for my attention. And if any questions, thanks so much. I'm going to stop sharing the screen.
Thank you, Patrick, for your very, very comprehensive presentation. We will get back to you during the Q&A session. And for the audience from all around the world, if you have any question, you can leave your question on the chat box. It's going to be either underneath the screen or it's going to be on the right-hand side. And then I will convey the question to the speaker. We have the next speaker. This is our own ISRT Vice President for the Americas, Terry L. And Terry is the nuclear medicine technologist and also an educator. And the topic that Terry will share with us for today's program is quality control of gas field detectors in nuclear medicine. Please welcome Terry L.
Good day to everyone. My name is Terry L. I am the VP of the Americas for the ISRT, and today I would like to very briefly discuss the quality control procedures of gas detectors used in the nuclear medicine department. Now, I know from having taught this topic to students in the past that as soon as I mention the term quality control, many start to daydream and drift off to sleep. I understand that. Certainly, quality control is not nearly as exciting as the newest iteration of PET MRI or the use of novel radiopharmaceuticals, but it is absolutely vital. Even our most mundane and routine tools are working at peak performance to ensure optimum patient care and radiation safety. Given the limited time available, I promise to keep details and mathematical calculations to an absolute minimum. I also realize that the newer detectors perform many of the QC protocols automatically, but I think that it's still important to understand the basics of the various assessments. So let's start with one of our most routine but indispensable pieces of equipment used throughout every day in the nuclear medicine department, dose calibrator, truly a workhorse of the department. Every dose of a radiopharmaceutical must be assayed prior to administration to ensure the activity and radioisotope is appropriate for each patient examination. According to current NRC regulations, administered doses must be within plus or minus 20%. The radionuclide dose calibrator, an argon gas pressurized ion chamber, is most commonly used for this purpose. First, a background assessment should be performed to confirm that there are no sources in or around the calibrator to interfere with subsequent readings. Contamination should also be assessed throughout the day. Most dose calibrators allow the practitioner to reset to a 0 level to account for ambient background activity. Next, a voltage test ensures that the electronics are optimal and the correct voltage is applied to the dose calibrator. This assessment varies between manufacturers, but generally requires the pressing of a particular button which initiates the system's auto zero test, usually less than 1 millivolt. This device should then display a stable voltage of about 150 volts and be consistent from day to day. The accuracy test is designed to ensure that the calibrator displays the correct readings throughout the entire energy scale one is likely to encounter. A reference standard is assayed 3 times in a dose calibrator, and the average reading is compared to the theoretical decay-corrected activity of the standard. Two sources of different photon energies are typically used. Qual-57 with a peak energy of 122 keV, which is close to that of technetium, and cesium-137 with a high energy peak of 662 are the preferred reference sources. Facilities using PET agents use positron-emitting agents such as gallium-68 or sodium-22 with activities of about 2 megabecquerel. Deviations greater than 10% from the decay-corrected reference activity indicate the need for repair. Accuracy assessment should be performed at installation, after repair, if the dose calibrator is moved, and annually. Here we have a typical worksheet used to calculate the percent deviation from the actual activity. The placement of a radioactive source, its volume, and the type of container may affect the dose calibrator's reading. Geometry dependence should be determined with these characteristics in mind. Potential volume and container type of effects can be evaluated similarly. Small volume of 37 to 74 megabecquerels of technetium is assayed in a syringe or vial. Precise aliquots of water are added to the container, measuring the activity with each dilution until the container is about 2/3 full. If any measured activity exceeds 10% error from the original activity, a correction factor must be used where the correction factor is equal to the true value divided by the value of the particular volume. Correction factors should be determined for each type and volume of container. Differences between the reading in a glass vial and syringe also need to be recorded. Note that the sample holder should be used consistently, as studies have shown variances by as much as 10% can occur depending merely on the orientation of the source. Geometry assessment should be performed if the dose calibrator is moved, repaired, or if the syringe or vial configuration is modified. It is important to note that significant attenuation of low energy betas and gamma rays from electron capture decay, for example with I-123 and indium-111, particularly in a glass vial, may require a correction factor by as much as 25%. So here we have the results of two different radioisotopes, thallium and technetium, measured in syringes of different volume. The linearity assessment ensures that the dose calibrator results are accurate over the entire range of radioactivity used from gigabecquerels to kilobecquerels. This test can be performed in two different ways. The decay linearity method does not require any extra equipment, but takes substantially longer to complete. Technetium source with an activity at least as large as the maximum activity typically used in daily practice is assayed several times a day until it has decayed to below the lowest level used in practice. Since the range of activities varies from several gigabecquerels from a generator eluate into the kilobecquerel range for thyroid uptake, this decay may take several days. The exact assay and time of the assay are plotted on semi-log graph paper along with the expected activities at the same time. And so we have the results here of 6-hour decay. And we see that plotted against time, against the actual values, it shows us a straight line. An alternate method for the linearity evaluations is to use a set of attenuation shields that surround the source and reduce the recorded activity by a known amount. The first step is to assay a maximum dose of technetium-99m used in practice. Activity is measured as each of the attenuation shields of known attenuation factor is placed over the source. The expected activity for each shield is calculated by dividing the activity by the shield attenuating factor. As with the decay method, a correcting factor should be applied for activity levels that exceed 10%. Linearity testing should be performed upon installation, after repairs, and quarterly. The linearity results displayed here demonstrate that as the various attenuators are applied, the measured activity declines as expected. With the appropriate calibration factors and decay times are applied, the resultant activities are within the 5% tolerance range. Consistency testing verifies that the dose calibrator is measuring precisely and that readings are reproducible day after day on all the various isotope settings. Since the dose calibrator is unable to distinguish between photons of various energies, it cannot discriminate between different radioisotopes. The isotope selector buttons multiply the current produced by the source by a specific conversion factor for each radionuclide. In older units, these values were hardwired into the electronics, but modern units allow them to be programmed into the readout as multiplication factors and can often be adjusted by the operator. Consistency testing should be performed daily. Measurement of the standard, cesium-137, is made on the appropriate isotope setting using channels associated with other commonly used radioisotopes. Though the results do not represent the actual activity of the source, the value for each isotope should be stable and not vary by more than plus or minus 10% from day to day. Some facilities will also perform a short-term consistency test by simply assaying the source 10 times in quick succession, expecting to achieve the same value each time. The constancy test should be performed daily upon installation, if the device is moved, and of course after repair. These results demonstrate that the value of the cobalt-57 reference source measured on technetium and thallium settings does not vary by more than 5% from day to day. Let's now focus our attention on survey meters. Survey meters are an essential component of any radiation safety program. They are portable, battery-operated, gas-filled ionization detectors used to monitor ambient radiation levels, either as exposure rates, for example, millisieverts per hour, or count rates, counts per minute. Survey meters can essentially be characterized according to their sensitivities. Two depicted here are examples of low sensitivity ionization survey meters, operating at relatively low voltages, up to about 500 volts. They are designed to detect high radiation flux of X or gamma rays, such as monitoring patients receiving radionuclides for radiation therapy. They operate over a wide range of exposures, 1 millisieverts per hour or 10 micrograys per hour to 10,000 millisieverts per hour or 100 milligrays. The electron signal readout depends on the energy of the detected X or gamma rays and therefore directly related to the exposure for all radionuclides. The more commonly used Geiger-Müller counter, or simply Geiger counter, is operated at a much higher potential difference, providing a high electron amplification factor and greater sensitivity. Geiger counters are best suited for low-level surveys, such as checking for radioactive contamination. For Geiger counters, the amplitude of the signal is independent of the energy of the incident radiation. Most commonly, Geiger counters read out in counting rates, counts per minute, but can approximate exposure rates, millisieverts per hour or grays per hour, using appropriate filter. QC tests of survey meters include a battery check just before use. The display indicates whether the voltage supplied by the battery is within the acceptable operating range. Confirm that the survey meter has not been contaminated. The background exposure or counting rate should be measured daily in an area remote from radioactive sources. Survey meters should be checked daily for constancy of response by measuring the exposure or counting rate of a long-lived reference source in a reproducible measurement geometry. Measured day-to-day exposure or counting rates should agree within 10% of the decay-corrected reference sample. Calibration of the survey meter is an assessment of accuracy. Many facilities have survey meters calibrated by a radiation safety office or by commercial calibration laboratories. The calibration report should indicate the reference source, the measurement procedure, the measured and expected exposure rates, and a dated sticker summarizing all of the calibration results should be affixed to the meter itself. However, it is possible for the nuclear medicine department to perform its own calibration, and I'll show you how using one mathematical formula that I found to be very, very useful. If the source is small and the distance between the source and meter large, then a point source geometry is approximated, and the expected exposure rate in millisieverts per hour in air is given by the inverse square law indicated here, where A0 is the activity in megabecquerels of the reference source at calibration. Lambda is the physical decay constant in days of the radionuclide comprising the reference source. Delta T is the time interval in days between the calibration of the reference source and the current measurement. And rho is the specific gamma ray constant in millisieverts per hour per centimeter squared per megabecquerel of the radionuclide comprising the reference source. And D is the distance in centimeters between the reference source and the meter. The reference source activity should be sufficient to yield an exposure of 1000 millisieverts per hour, and the exposure rates should be measured on each scale and by appropriate adjustment of the source to meter distance at two readings, 20% and 80% of the maximum on each scale. For all readings, the expected and measured exposure rates should agree within 10%. Survey meters should be calibrated using suitable long-lived reference sources at installation, annually, and after any repair. So here we have a typical survey meter report form indicating environmental conditions, source information, various ranges attested, and any percent error for each. I would like to leave you with one very last but very important message. All too often, I found that radiographers would complete the QC protocols, write down the results, and continue with the daily responsibilities. Cannot impress upon you enough how important it is to actually review the results to ensure that they meet specifications. This is particularly vital when subtle changes start to show trends or more significant inaccuracies. Thank you all very much for your time and attention in reviewing this very important issue. And I hope to meet you all either online or in person at the Ireland World Conference in August this year.
Thank you, Terry, for your comprehensive presentation about quality control of the gas field detectors in nuclear medicine. And we will come back to you with the Q&A session. For the next speaker, we have Lucas Gross, and he's an instruction and clinical coordinator at Diagnostic Service Department, Radiation Safety Officer at University of Middle from the US. The topic today is radiation safety, technological advancement, radiopharmaceuticals, and technical pitfalls in advanced PET-CT technology. The floor is yours, Lucas.
Hello, everybody. Good morning, good afternoon, and good evening. Thank you for joining me for this presentation. Thank you, Napapong, for that introduction. My name is Lucas Gross, and I'm going to be presenting on radiation safety and radiopharmaceuticals and PET-CT. I'm the radiation safety officer at the University of Finley, so I'm going to look at things from the nuclear medicine safety point. I have nothing to declare, no financial disclosures or conflicts of interest. I'm going to be talking about nuclear medicine distinction, what makes it different than the rest of radiology and radiography. PET-CT basics, radiation safety, and radiopharmaceuticals. Why is it called nuclear medicine? Everybody take a moment and think about that. Why is it called nuclear medicine? We use radioisotopes. Why isn't it called radioisotopic medicine? We use radiopharmaceutical medicine. What makes nuclear medicine different in radiology than the other disciplines? So what we have here is our nucleus. We have our neutrons and our protons, and then we have our electrons and the shells that are around it. And what happens with everything except for nuclear medicine to produce our radiation is we have our electron in one of the outer orbits, and it's going to have an interaction happen, and there's the interaction, and it's going to displace it from an inner shell to an outer shell. And at that point, it becomes radiation. And that radiation is then going to be given off in the form of characteristic radiation. And that right there is actually X-ray. Once it loses or gives off that characteristic radiation, it falls back to the lower orbital, and then it becomes stable again. This is X-ray. Now, this is what makes nuclear medicine so different, so unique. We have our nucleus, proton and neutrons, and we have our electron shells around it. The nucleus itself is radioactive. It's unstable. So what will happen is it'll emit a photon. And in this schematic here, I'm showing a gamma ray being given off. So the gamma ray is given off by the nucleus in an attempt for it to become less radioactive or decay or reach a level of being stable. So the actual radiation itself comes from the nucleus. So that is where the name nuclear medicine comes from. So that's the basis of nuclear medicine, and I'll talk about some emission versus transmission, and this is the premise of all of that. By definition, nuclear medicine is a medical specialty that makes use of radioactive byproduct materials for diagnostic and therapeutic purposes with unsealed sources. Here's the basics. Very, very generalized here. I apologize if there's some other nuclear medicine people in attendance here. I'm trying to cater to everybody. But in nuclear medicine, we are going to use a radioactive tracer. That tracer is going to track a specific function in the body, and it'll allow us to monitor how that organ or that particular mechanism is working normally. The body will not know that we have manipulated it in any way unless we do a pharmacological intervention. So we just want to see what the body is doing naturally on its own. So we use a small amount of radioactivity and a small amount of a tracer to be able to allow us to take the pictures. The radioisotopes or radionuclides that we use typically have a reasonably short half-life and a lower energy, but they're not particle emitting. Whereas when we do a therapy, we want it to be particle emitting. So what is PET-CT? PET is positron emission tomography fused with a computed tomography. It combines both of them together. Most of our PET-CT scanners, they're either on the same bore or they're two separate bores, but the table or the couch, they're connected, and the patient will go through both of those bores or gantries. So it's called a hybrid camera. Here's what it looks like on this particular PET-CT scanner. This first part here is the CT, and then the part that's at the rear of the camera is the PET. So why do we do both? Why do we need a hybrid scanner to do this? PET allows us to see what's going on with the function of the body. The CT, very important, and lets us see the anatomy of the body. When we fuse those both together, we get the anatomy and the function, so it's the physiology of exactly where it's located at in the body. Very important, PET-CT is better than PET or CT alone for the patient management of most diseases or diagnoses or conditions. And why do we have to fuse them together? You need to fuse them to avoid the confusion. Very important, and we'll do that with other modalities as well. PET MR is a growing field as well, and the MR is very good for particular organs in the body over CT. Diagnosis, something completely different. PET or CT or MR, none of those can actually diagnose a patient. That has to be done through a biopsy or a tissue sample. We can tell the physician, where we should look at, where there's a suspected lesion or metastases or tumor, and then an actual sample of that has to be taken, sent to pathology, looked at microscopically, frozen, stained, sliced. That's the only way that we can diagnose it. So all of this is more for monitoring the patient to see how they're responding to treatment, to see how successful a surgery was, to see if a medication or chemotherapy or radiation therapy is working. The evaluation. PET isotope considerations. It's going to emit two 511 keV annihilation photons that are penetrating, and then it's going to emit positrons that are non-penetrating. Generally, these two 511 keV are positron annihilation. That's how they're referred to. And that means that when we administer it to the patient, or when we produce it, it's going to be radioactive from that point moving forward until it decays down into a stable non-radioactive chemical. So a lead apron, it's ineffective. We don't actually want to use that when we work with PET isotopes. For CT, it is appropriate, and I'll get to that later, but it's not appropriate for PET isotopes with that higher 511 keV. With CT, you generally have a 100 to 120 to 130 kVp, and you have the lower energies keVs. The radioactivity amount, we can increase it with the patient, because we need to get more counts from the patient. We'll need to give more radioactivity. But in different PET systems, if there's a higher sensitivity at a digital crystal or a digital detector, we reduce the amount of radioactivity that's given because we can detect more counts coming from the patient. Sources of radiation exposure in PET CT, the production, the cyclotron in the generator, and then the dose preparation and administration. And the big one for PET and for CT is the patient. In CT, the patient is the largest form of scatter. For PET, the patient is generally the highest form or highest exposure for most departments that don't have a cyclotron or a generator on site. And we have the X-rays as well. So here is how we produce PET isotopes. This is a cyclotron. So the cyclotron is actually enclosed in concrete walls that are on these tracks that you can move back and forth. And it's about 8 to 12 inches thick, depends on the cyclotron. It will vary. And then inside of it, we have these ports. And then this right here is a blown up picture of those ports. On the ports, we can connect up a target. And what we'll do is we will use a liquid or gaseous target, and we'll bombard that. And then we will produce our radioactivity from there. On this example, there is not a target on the port. And then on this port here, there is a target that is on there for production of radioactivity. The other form that we use in PET often is a generator. So the generator, it's what we'll do is we will elute the generator. And these right here are the basic generators, but we have these devices to actually deliver pretty rapid doses infusions into the patient. So the generator will sit inside of one of these, and then we will inject it into the patient very quickly. Inside of here, this is all shielded. This right here is all shielded, and then this right here is all shielded. It's either shielded with lead or with tungsten. Why lead or tungsten? Lead is very dense material. It's also reasonably priced. Tungsten has a higher atomic number, but it is more expensive. So you need to weigh your measurement of, is this a tungsten shielding or is lead appropriate for it? If you have deep pockets, then go with the tungsten. If you have big muscles, go with the tungsten as well. But we'll talk about time distance shielding as well a little bit. So after we produce the radioactivity, the PET radioisotope, we're going to put it into a lead pig or a tungsten shielding. And this right here is another example of the tungsten shielding, and then the generator right here as well. And this is a dose delivery system. So inside of this, there's a whole bunch of lead and tungsten and shielding for the automatic infusion into the patient. With PET, you need to be reminded that everything's going to be heavier. So with a syringe shield, a lead syringe shield versus a tungsten syringe, it would have a significant amount of weight. With PET, we need to be using tungsten because it's going to be directly held in our hand. So time distance shielding, there's not going to be much distance in between our hand and that PET radioisotope. So everything's going to be a little bit more dense and a little bit heavier as well. So get back to the PET radiopharmaceutical. After we inject the patient, that patient is a walking radioactive source. So we inject it. This is how we detect it inside of the PET camera itself. But this is what's going on everywhere that the patient goes. They're emitting the 2,511 annihilation photons, the positrons, which are penetrating. So we need to be conscious of that. So after we inject a patient, depending on the study, we want to make sure that we have them shielded. So this right here is a nuclear medicine PET CT department. And these are the injection rooms. So all of these walls need to be shielded with lead of some sort. And then all of the red areas, those need to be shielded as well. The difference is with the CT, there needs to be at least 1/16 inch shielding in there for the CT, depending if it's getting hit with the primary beam or it's secondary radiation. And the PET, it needs to be shielded for the 511 keV. So a primary beam from CT is somewhere between 110, 120, 130 on most scanners. The PET radioisotopes, they're all 511 keV, so they're going to require more shielding, so more lead in the walls. So when you go to inject a patient, you need to be conscious that that door is going to have lead in it, and it's going to be very heavy. So it'll be difficult to stop, so don't put your foot in the way of that door. Again, inside of the scanner, here's the gamma rays or photons that come off, and they're going to hit two crystals on the other side, and then this is the annihilation reaction. So overall, we're going to take a radioactive patient, and we're going to put them inside of our PET scanner, the PET crystal, the black, and we're going to detect what is coming off from the patient. So lead aprons, I talked about that before. They only have 0.5 millimeter of lead shielding. So it's really good against energies that are 100 to 120 keV, but 511 keV, it basically makes them useless, and it could be actually harmful as well. The reason is, whoops, the brimstone lung will come off. So we have our original photon that comes in, and then the brimstone lung comes off of that. I'm not sure what's going there, but so, you know, who's on the other side of that lead apron? You are. So you're getting significantly more exposure, and it's been degraded down, so it's a lower energy, so it's not going to penetrate directly through you. It's going to hit off a few critical organs inside of your body or your bones and really increase your radiation absorbed dose. So after we get the radioisotope and we're ready to inject the patient, we need to take some time before we inject. We need to do all of the explanation before we inject them, because that dose is inside of a pig right now and it's shielded. So essentially our radiation exposure is very low, and ALARA, as low as reasonably achievable, we want to keep it as low as we can. So before we administer it, we want to explain the study, get consent, check to make sure that they are prepared, there's no contraindications, and we're going to make sure that the patient is going to be comfortable on the camera as well. We need to also make sure that they are able to void. If they're not able to void, we'll need to make arrangements for that as well. After we administer the patient, we want to stay away from them. That's the most radioactive that they're going to be, because radioactivity is going to decay over time. So we're going to inject them, and we're going to leave them in one of those uptake rooms that I showed earlier. We're going to keep an eye on them. They're going to have a call bell. We could have a video monitor in there. But we're going to let the radioactivity be taken up in their body and then be cleared out before we take pictures of them. Distance. Inverse square law, very important in nuclear medicine. So if we take a single step back, we will reduce our exposure greatly. So the inverse square law says that if we double our distance, our exposure will go down by 1/4. So that's very important. So if you need to answer a question, take a step back from the patient. Here's our shielding. I know I've harped on this a lot, but shielding is very important in PET. So we have half-value layers, and there's also 10th-value layers, which I don't have time to get into in this presentation. But everything is going to be a little bit thicker, and it's going to be a little bit heavier. So this is the rings that go around a dose calibrator. Here's our L block for fluorine 18, which is our most common PET radioisotope. Its half value layer is 4 millimeters of lead and 34 millimeters of concrete, compared to the traditional technetium-99m, which only requires 0.26 millimeters of lead. Inside of the department, we're going to have some gamma counters, and we're going to have some radiation monitoring devices of some sorts. We're going to have the personal dosimeters that we wear, but we're going to have a gamma counter just in case there's a leak in the department. Typically, these go off when any PET patient will go by. There's an alarm that'll go off, some sort of audible alarm or a visual alarm. And then if we suspect that there's a spill, we have our Geiger-Muller surveyors. So oncology scans, I'm going to talk about just the big ones right now that are catching a lot of headlines. This is by no means an extensive list. The main one I'm going to talk about is fluorine-18 fluorodeoxyglucose. It's used for multiple types of cancer. And then prostate cancer, those are gaining a lot of traction as well. Fluorine-18 flucalon, which is called Aximin, and then gallium-68 PSMA. And then I talk about neuroendocrine tumors using copper-64 and gallium-68 dotatate. F18-FTG. FTG is a glucose analog. It gets taken up in the body just like regular glucose does. The difference is that once it gets into the tumor cells, they're going to remain in the tumor cells much longer. And that's going to allow us to take the pictures. So if it remains in the tumor cells and clears out of the background tissue areas, then we have a higher target to background ratio. And that's the goal of any ideal radiopharmaceutical. You want a high target, low background contrast. So what's going on is regular glucose, it gets taken up into the cell and it goes in through the hexokinase, and then it will go on through the glycolytic metabolic pathway. And that's the normal production of glucose in our body. The difference is that FTG, our synthetic glucose, it gets taken up by the hexokinase, and then it gets trapped into that area there, so it can't progress anymore. So over time, it's going to be a buildup of that radioactivity into those tumor cells, and we'll be able to detect the metabolic activity of those because that'll be proportional to the rate of the metabolic activity. Here's a FDG study. This is a total body. On the left is the maximum intensity projection. It's a good looking picture to give you an idea of where to start at. Diagnostically, not that relevant, but it is a good looking picture, and that's what we see most often. Over on the right is a fused image. It's the PET and the CT fused together. Normal biodistribution of F18-FDG. The brain has to use glucose. It only uses it, so we're always going to see the brain in an FDG study. Another area that we're always going to see is the bladder and the kidneys. In the kidneys, it gets cleared by the calmix, and so we'll always see the kidneys and we'll always see the bladder in some form. The next area that we may see, depending on the patient, is the heart. So on this patient over here, it is a female patient, but there's not a lot of heart activity. And then over here on the right, it is a male, but we see a lot of heart activity. This has nothing to do with being male or female. This has to do with the patient following the preparation, and one of the preparations is a low carbohydrate diet. So we want to ensure that the patient is on a low carbohydrate diet for some time before we actually administer the FDG. And that's on the technologist. We need to ensure that they're doing that because we can't see much that's going on outside of this. And what will actually happen is we're going to miss some tumors that could be near the heart itself. Here's an example of lymphoma. Over here is Hodgkin's, so PET-CT, FDG, perfect for staging. So the patient was an early scan where they were diagnosed, they received some treatment, and then over time, we don't see any more of those uptake or focal uptake within the body. Over here is a T-cell lymphoma as well. So the scan region is really going to vary depending on the type of malignancy. Here is the Aximin for prostate cancer imaging. This is a normal biodistribution on the patient. What you'll see is these red arrows here. You're going to see muscle uptake. It's greater in the upper extremities than the lower extremities. And then we're going to see the kidney activity as well. You're going to really be able to define where the pancreas is. That's the P here. And then you'll have liver uptake as well. With this study, it's very important, though, that you have the patient void immediately prior to injection, and then you start imaging after injection. And you're going to start down here at the pelvis, where traditionally with FDG, oncology studies, you'll start at the base of the skull. Here's another example of the Aximin. We have uptake in this area. You can see the kidneys really well. You see the pancreas, you see the liver, but we also see a couple of areas of focal uptake on the skeletal system. So here's the axial slices of those. It's really clear to see where the disease has progressed to. Again, the MIP will give you an idea of where to look, but it's the axial slices or the sagittal or the transverse that will allow you to actually pinpoint where exactly that's it on the fused images. Here's gallium-68 PSMA for prostate cancer. Here's the different normal biodistributions of it, depending on where the disease is. Good looking pictures, very, very good for detection of prostate cancer. It's coming online in the United States, and we're very excited about it coming. Here's neuroendocrine tumor imaging. Now there's two agents for this. There's the gallium-68 and the copper-64, which are both PET radiopharmaceuticals. Our traditional is the indium-11 octreotide. So as you can see here, the comparison between the traditional versus the PET is really remarkable. You have a higher sensitivity and a higher resolution as well. Here's another example of the gallium-68 dotatate, that spot. The MIP image, get an idea. Here's the fused image, and then here's the CT. So the function with the anatomy. For cardiac imaging, we can get it produced through a cyclotron, and that's our ammonia-13 and nitrogen-13 ammonia, or we can get it produced through a generator, and that's our rubidium-82 chloride. Here's what the images look like. Very well defined, higher extraction rate than the surrounding area. Very, very, very good images. With this study right here, the importance of it is a very short half-life, so you need to ensure that you infuse it very rapidly and begin imaging immediately after you begin the infusion. For neurological radiopharmaceuticals, I've only covered 3. Again, this is not a comprehensive list by any means, but we have some that estimate the amyloid plaque density in the brain, and that's for the use of Alzheimer's disease progression. And then we also have epileptic seizures in the brain, and that's F18-FDG. And then we also have it for striatal binding in the brain. And for that, we're looking at the caudal nucleus and the putamen, and we use that to evaluate for essential tremors, benign tremors, for Parkinsonian syndromes or diseases of that nature. So one thing that we can do as a technologist to ensure that we get a good study is the bladder, the kidney and the bladders. Those are big ones. So what you have here is there's a lot of activity into the kidneys, and in this area, it's an F18-FDG study, and it's in the Kalman system, the clearance part of the kidneys, and it hasn't gotten to the renal pelvis yet. So this patient right here, maybe on their next study, they should be administered, or during this time, they could have been administered a diuretic, Lasix or furosemide, to help clear out that activity, because all of the counts that are around that, we can't really see, and that's called a halo artifact. It happens quite often with the bladder, and there is processing and applications and software that will correct for this. But again, if you can get a true image of what's going on rather than reprocessing or anything, I'm always a better fan of that, because then you could introduce a processing artifact, and then you're not really sure of what is there and what is not there. But the software and the applications are improving every day. Take-home messages: use appropriate shielding. Beware that PET, you need tungsten and lead, and you need a lot more of it. The second thing, the patient is the radioactive source. Don't stand there and have a conversation with them while you're right next to them in close proximity. It's okay to answer questions, but remember, you're going to be doing this every day, all year. Keep that in mind. You want to take a step back. You want to limit your time and increase your distance from the patient. And then there's many, many new radiopharmaceuticals that are coming online. I only covered a very small fraction of what is available and what is being done right now. Thank you for your attention. If you have any questions, I'll be available with the other panelists during the Q&A session. Thank you very much, and I will see you soon.
Thank you, Lucas. That was very comprehensive presentation from you. And for the audience, if you have any question or any comments, please do so. I will take the question to the speakers right after the Q&A session. And here comes the time for the last speaker for today. He is Kittiwat Kamwan. Dr. Kittiwat Kamwan, he is the Assistant Professor and Director in Radiological Technology Program at Faculty of Medicine, Chulalongkorn University in Thailand. And the topic that Dr. Kittiwat will share today is theranostic basic concepts and challenges of nuclear medicine technologies in the era of precision medicine. Please have Kittiwat Kamwan.
Hi everyone, I am Kittiwat Kamwan from Chulalongkorn University, Thailand. It's my great honor to be an invited speaker for the ISRT webinar. So today I will talk about the theranostic basic concept and challenges for nuclear medicine technologies in the era of the precision medicine. Nuclear medicine is the field that combines computer technology, advanced medical instrumentation, radiation physics, and patient care to diagnose and treat the disease. Right now, we are living in the era of the precision medicine. Precision medicine is an emerging approach for disease prevention and treatment that take into account people's individual variation in genes, environment, and lifestyles. In the concept of the radiopharmaceutical therapy, is quite different from external beam therapy. For the external beam therapy, it requires the knowledge of the tumor location, whereas the radionuclide therapy requires the knowledge of the tumor biology. When we administer radiopharmaceutical into the body of the patients, the agent distributes throughout the body and then bind to the target cell and clear from the non-target cell. Prolong exposure to target cell and give a larger radiation dose to the target cell than to the normal cells. For the theranostic, this is the combination between the therapy and diagnostics. This is the state-of-art treatment in the modern nuclear medicine. As you can see in this slide, we do the imaging based on the gallium-68 DOTA for the diagnosis by using the PET-CT scanner, and then treat the cancer or the tumor by the lutetium-177 DOTA. This is for the treatment. So this is the concept of the theranostic. We know what site will be treated by the diagnostic scan by using the radionuclide that emit the positron or gamma emitter, such as fluorine-18 or gallium-68, and then confirm that is treated for the post-therapy scan to demonstrate achievable tumor doses by radionuclide that emit the alpha or beta emitter, such as radium-223, lutetium-177, or actinium-225 for imaging and therapy. This is the theranostic concept. This slide shows the study of the Hope et al. That published in the JNM in 2019 regarding the procedure standard for somatostatin receptor-based peptide receptor radionuclide therapy with lutetium-177 dotatate. So they do the pre-treatment imaging by using the gallium-68 dotatate. And then this figure shows the post-treatment for the first cycle, second cycle, and third cycle, and the fourth cycle. So you can see here the progression of the disease is decreased after administration of the lutetium-177 dotatate in different therapy cycles. So that's why we call theranostic concept. We see what we treat, and we treat what we see. This table shows the property of the radionuclide that use the theranostic, such as the yttrium-90, iodine-131, samarium-153, lutetium-177 that emit the beta particle, and the radium-223 and actinium-225 that emit the alpha particle. They have the difference of the half-life and very short range of the particle in the tissue. At King Chulalongkorn Memorial Hospital, we start using the theranostic in the prostate cancer and neuroendocrine tumor by using the gallium-68 PSMA and lutetium-177 PSMA, and gallium-68 and lutetium-177 dotatate. This is the number of the patient from February 2018 to around August in 2019. So you can see here we have about 48 patients for the gallium-68 PSMA, and then only 21 patients that passed the criteria for the treatment. And also for the gallium-68 dotatate, about 13 patients, and then 10 patients passed the criteria for the treatment by lutetium-177 dotatate. And this is the example of the gallium-68 PSMA 11 PET-CT imaging. The patient was administered the activity around 5 millicurie and do the imaging at 1 hour after injection. And this is the first patient for the lutetium-177 PSMA treatment in Thailand at King Chulalongkorn Memorial Hospital. So this is the process of the PSMA injection, and then we also do the SPECT-CT scanning for the imaging and for doing the dosimetry after the treatment. And this is our staff that involved in this treatment. And this is the process of the lutetium-177 dotatate labeling for the neuroendocrine tumor treatment. And we have to do the quality control in order to verify the quality of the labeling that should be that the quality should be enough in order to use with the patients. The one thing that we need to be concerned regarding the theranostic is about the dosimetry. For the diagnostic, we use the low activity that less than 1 gigabecquerel with the short life of the radionuclide that emit the gamma or positron emitter and concern the stochastic risk. And we need to do the model-based dosimetry in representative group or volunteer or the patients and optimize the image quality and try to minimize the radiation-associated risk. For the therapy, we use the high activity that greater than 1 gigabecquerel with the long life radionuclide that emit the alpha or beta emitter and determine the deterministic damage and stochastic risk as well. And we need to calculate the patient-specific dosimetry by maximize the tumor absorbed dose and minimize the absorbed dose to the organ at risk. This is the difference concept of the dosimetry in diagnostic and therapy in nuclear medicine. In order to determine the dosimetry in nuclear medicine, we use the internal dosimetry concept that according to the Medical Internal Radiation Dose Committee of the Society of Nuclear Medicine and Molecular Imaging, or SNMMI. This is the equation according to the Merz equation. The dose to the target organ equal to the time integrated activity in the source organ and multiplied by the S value from the source to the target organ. This is the simplified equation according to the Merz method that used to calculate the dose in nuclear medicine. And then if we need to calculate the dosimetry, we need to do the imaging in several times, at least 3 times, in order to determine the time activity curve. And then when we integrate the activity under the curve, we will get the time integrated activity, and we use this biokinetic data to determine the absorbed dose in the target organ. So when we divide the time integrated activity with the injected activity, we will get the time integrated activity coefficients, or the former name is the resident time, as you can see here. In order to determine the dosimetry, as I mentioned previously, this is the example of the peptide receptor radionuclide therapy treatment, and we do the imaging by using the planar imaging. For the lutetium-177, the energy of the beta is about 490 keV, with the gamma energy about 113 keV, about 6%, and abundance for the gamma of the energy 208 keV, about 11%, with the physical half-life about 6.6 days. And we need to be careful about the external and internal exposure, and also the contamination. This is the example of the dosimetry that we scan the time at the 5 minutes, 4 hours after injection, 24 hours, 84 hours, and 120 hours after injection for doing the dosimetry. And the one thing that should be done in the lutetium-177 dotatate is about the nephrotoxicity evaluation in order to avoid the renal failure. This is the example of the planar imaging of the lutetium-177 dotatate. And this is the example of the SPECT-CT imaging at 4 hours after injection and 24-hour injection. So the uptake of the lutetium-177 or the tracer that used for the treatment should be identical to the diagnostic scan. So this is the biokinetic data of the lutetium-177 dotatate of the first patient at King Chulalongkorn Memorial Hospital after scan time at 5 minutes, 4 hours, 24 hours, 48 hours, 120 hours after injection, with the inject activity about 190 millicurie. You will see the time activity curve in the kidney, the green line here, the liver, spleen, and the bladder. And this is the time activity curve in the whole body after lutetium-177 dotatate treatment. And we scan at the several times, as I mentioned to you previously. And then we calculate the absorbed dose to the kidney in order to determine the dose to the renal to avoid the renal failure. With the moderately weak of the beta particle emitting radionuclide, such as lutetium-177, so only the self-dose need to be considered. And the dose limit for the renal is about 23 gray. And if you need to calculate the absorbed dose, you can calculate according to the method, and then use the S value from the published data that they provide the adult male kidney S value and the adult female kidney S value according to this slides. And this is the result of the resident time in the several source organ in the kidney, liver, spleen, urinary bladder, and the whole body. Kidney is one of the critical organ for the lutetium-177, PSMA, and dotatate. And in our study, the kidney received the dose about 2.8 gray. It's about 0.4 gray per gigabecquerel. If the patient underwent the treatment about 4 to 6 treatment cycle, we receive the absorbed dose for the kidney about 11 to 16 gray. Is still below the dose limit of the 23 gray for the kidney. And when we compare the dosimetry of the kidney with the other study, so you can see from this table is quite comparable with the other study. For the unprotected of the lutetium-177 dotatate, so the dose to the renal is about 2 times compared with the protected procedure. What does it mean? It means the patient received the amino acid about half an hour before the treatment in order to protect the kidney. So that's why you will notice that there are two values for the dose to the kidney with unprotect and the protect. So this is the concept of the treatment for the lutetium-177 dotatate. And this is the example of the second patient for the lutetium-177 dotatate treatment at King Chulalongkorn Memorial Hospital. So the patient has the tumor at the liver, as you can see here. And as I mentioned, the dose constraint for the radionuclide therapy in nuclear medicine. So the cumulative dose for the organ at risk should be concerned. For the bone marrow, is about 2 gray. For the kidney, is about 23 gray. So we need to calculate the dose. We need to concern the dose in the bone marrow in order to avoid the bone marrow suppression, and for the kidney in order to avoid the renal failure, as I mentioned previously. The lacrimal gland is about 40 gray, liver 32 gray, and salivary gland about 20 gray. And this is the example of the result of the lutetium-177 PSMA radiation dose in the kidney. So in our hospital, the mean absorbed dose is about 0.8 gray per gigabecquerel. It's a bit higher compared to the other study. As I mentioned, the kidney are the relevant critical organ for the lutetium-177 PSMA. And the mean absorbed dose in our hospital is still below the dose limit of the 23 gray. For the bone marrow in our hospital is about 0.02 gray per gigabecquerel, is comparable to the other published data. And in overall, if we administer the activity about 200 millicurie, the patient will receive the radiation dose for the bone marrow about 0.14 gray for the lutetium-177 PSMA INT. How about for the radiation dose from the gallium-68 PSMA? So this is the study from Ken Herman and Afshar et al. That published in the JNM and EJNMMI. The kidney is the critical organ for the gallium-68 PSMA, similar to the lutetium-177 PSMA as well. And the dose followed by the urinary bladder wall, spleen, salivary gland, and the liver, with the inject activity about 5 millicurie approximately. So this slide shows the clinical result of the metastatic prostate cancer treatment at King Chulalongkorn Memorial Hospital. For the imaging by using the gallium-68 PSMA, so you can see here from the anterior view of the planar imaging, you see the metastasis, like the bone metastasis at the right shoulder and the both knee of the patients. And this is the posterior view. And also at the thoracic spine of the patients, the patient has the bone metastasis as well. After 2 months of the treatment with the lutetium-177 PSMA, so you can see here, it seems the progress of the cancer of the bone metastasis is reduced, right? You can see here at the right shoulder and the both knee. So we got a very good outcome of the treatment based on the theranostic. And this is the image of the year from the Theranostic that published in the Society of Nuclear Medicine and Molecular Imaging meeting in 2018. This is the research from the group in Germany. The gallium-68 PSMA 11 PET on your left side, and then after the treatment with the lutetium-177 PSMA 617, that this is show the image of the 8 patient with metastasis prostate cancer who exhaust standard therapeutic option. So you can see here, this is the before the treatment. You will see the bone metastasis or also the metastasis of the cancer in the body of the patients. And then after that, after the treatment of the lutetium-177 PSMA, it seems it disappear, right? It's like a miracle of the treatment. And 1 year later, for the Theranostic session, this is the image of the year of the SNMMI meeting in 2019. This is the novel radio tracer that can detect 28 cancer types. It paving the way of the development of the new Theranostic. So you can see here, this is the different type of the cancer in different patients, but inject with the same radiopharmaceutical of the Theranostic with the gallium-68 FAPI or fibroblast activation protein inhibitor. So this is the another step of the Theranostic. So they try to develop the radio tracer that combine with the FAPI and then can treat the several cancer similar to the gallium-68 FAPI as I show you in this slide. In summary, Theranostic involved in radionuclide pair that intimately tied to radiopharmaceutical therapy. See, then, and treat, and may be used for the dosimetry. Matching half-life with the kinetic of radiopharmaceutical therapy is the critical point. And the imaging will be very different depending on the therapeutic agent and expanded scope of the radionuclide. And alpha radiopharmaceutical therapy is ascendant due to the high LET particle, and it can deliver directly to the cancer cell. This is the trend of the Theranostic right now in nuclear medicine. This is an exciting future. Nuclear medicine will continue to be a field at the forefront of modern clinical medicine and technological development, as we have the development of the cancer detecting and cancer killing agent, advancement of the fusion imaging, and development of the new radiopharmaceutical for diagnosis and therapy. This is the Theranostic. Nuclear medicine used to be the unclear medicine, right? But right now we are moving to the modern nuclear medicine in the era of the Theranostic, the advanced and modern nuclear medicine. This is all of my talk today. So thank you so much, everyone, for your kind attention. And I would like to thank ISRT for giving the opportunity for me to give a talk in this online webinar. Thank you so much.
Thank you so much, Kitiwat, for sharing your experience and your team at Chulalongkorn University in theranostic nuclear medicine. And this is very new to Thailand and to, I believe, to others. Colleagues also. And now here comes the time for the Q&A session. I got a couple questions from the audience, and of course we have two panelists today, Donna Newman and our CEO Dimitris Kasiferakis. Donna, you have any comments for the talk for tonight?
Well, I have to say that I am just amazed at the expertise that were brought forward. Having been a nuclear medicine PET-CT technologist for the working in the field for 30 years, you have really brought forward best practice for our members from around the world with the latest technology. And I don't think we could have had better speakers than we have today. So I thank you all for bringing the importance of QC, the importance of best practice, and how we're using our new technology. I'm looking forward to hearing from you about how we're going to educate, how we're going to do our QC, how we're going to actually keep up with this new technology. And so I'll be interested to see what you have to say.
All right, thank you, Donna. And Dimitris, do you have any comments on this?
Yeah, thank you, Napapong. Although I'm not familiar that much with the nuclear medicine, I'm impressed on the quality of the presentations and the content, scientific content. Are very good speakers they have delivered to our audience. And I'm very proud that we as radiographers and nuclear medicine technologists, we can have a very important role on patient care and patient safety, as well as a team players, to the journey of our patients towards their health. Thank you to the speakers.
All right, thank you, Dimitris. Now it comes the time for the Q&A session. I got numbers of questions from the audience, and the first one is about the quality control in hybrid imaging from Patrick. Your talk about PET-MR, and there's a unique QC procedures for technologists in both PET and MR. Just want to learn from you what you do in this, because we know that you talk about like zoning, you talk about MR zoning, but when it comes to the hybrid technology, how would this make things different to deal with the situation? Because it's not only MR, because you have PET also. That's the first question. And the second question is the role of the technologist in terms of quality control.
Where I work, and it's a really good question, where I work, just like you said, that there is two pieces of equipment. So you do have to know, you have to understand both. We're very lucky that we have technologists that are both MR technologists and nuke med that work in the nuclear medicine field. So the biggest thing, though, for quality control is that you have to be able to do a quality control for the PET scanner. You have to understand that. You do have to understand the quality control from the MR side. And that's pretty much really what it is. I mean, you're trained as a technologist when you go to school for both, but it is something that is a hybrid imaging, just like SPECT CT and PET CT. I mean, you're bringing a CT in, so now you have to understand. And, we're not all X-ray technologists. I was an X-ray technologist first before I went into nuclear medicine, because it's been in the field for about 25 years, and that was the pathway. But not all of us are very familiar with the CT, the X-ray side of it. So you do have to understand and just learn what you're supposed to do as quality control, be able to visualize what's a good image, what's a bad image, and does the machine pass everything. So that's really what you have to do. You just have to be aware of both pieces of equipment and know the steps.
All right, thank you, Patrick. I think the same question goes to Lucas, but this is the Lucas talk about PET CT instead. So what about in PET CT? What's the role of technologists in both like safety and quality control of the equipment, since this is the hybrid imaging? I know that in the US, the different places have different education system. Some places you just go for diagnostic, some places you go for nuclear medicine only, some places you go for therapeutic only, but in some places you go 3-in-1. So like in your case in the US, what do you do with this?
Thank you for the question. So in the United States, we have two pathways. You have the PET scanner, which you get a traditional nuclear medicine education, and then you can go on and get additional certifications in education in PET and in CT. Or you could do the traditional route, where you're an X-ray tech and you have that X-ray and that CT training, and then you go on for the nuclear medicine education after that. I think the most important thing is the technologist needs to know the daily QC of the equipment versus the weekly QC versus the monthly, bi-monthly, quarterly. And one of the most important things that you can do as a technologist is look up what is accepted out there. I know a couple of organizations, they have guidelines on how frequently you should be doing testing. And in your department, you need to have that talk with your dosimetrist or your physicist and ensure that you have a daily quality control. And as the one of the speakers pointed out earlier, you need to make sure that you're looking to see if it passes or not, because everybody can check a box. So the quality control and the quality assurance, those are two separate pieces. The quality control is performing the test, and all technologists are responsible for that. And then the quality assurance is, did it pass? Is it within the parameters for this to give diagnostic quality images? And I think both parts are very valuable. And a lot of us, we check the box because a lot of our systems have it automated now. The auto QC in the morning, the auto warm up, or the Surview preview, and then scanning the actual Phantom. We just go through the steps and we overlook it quite often. And I think you need to really remind yourself what needs to be done and what needs to be performed. And an easy way for you to do that is we have computers available. Make an Excel sheet that when you enter in these numbers and you save it electronically, it'll yell at you if you failed. It'll turn it red. It'll let you know that something failed. That beats the pen and paper every day. That's a good way to keep yourself in check, because how many times have we walked into a room, forgot why we went in there? We do the same thing with the repetition of our jobs in the QC. We need to remind ourselves of the importance and the significance that will play on our scan quality.
Oh, thank you so much, Lucas. And I think as the ISRT, as a representative of the technologists and radiographers worldwide, we are very active in this. We have the position statement ready on quality control. And I would like our president, Donna Newman, to talk a bit about this for the role of technologists in QC.
Thank you, Napapong. I appreciate the question. I think it's important that we set a standard around the world to ensure that people know that the radiographer is the term used globally. In the United States, nuclear medicine technologist, but in the world, the nuclear medicine radiographer actually has a role in the daily, the quarterly, and the yearly in the performance. We do believe in the team approach, that you work as a team in the imaging department with the nuclear medicine specialist, the radiologist, the physicist, and the technologist. But the radiographer has a role in performing the QC every day, quarterly, weekly, monthly, and yearly beside the physicist, or performing it and then having a physicist review it. So we want countries around the world to know that we stand behind that, and that we believe that you're educationally prepared and clinically competent to do that. And please go to our ISRT website, to the position statements, and download that if you're having trouble in your country with this aspect of it, and bring that forward to the authorities so that they allow you to perform these things. You are the one performing the exams. You need to know how the equipment works, and you will see the errors that come up first before a service engineer, a physicist, or a physician will see them. So we stand behind that. Thank you, Napa.
All right, Donna, thank you. And the next question, I think, goes to Teriel. Teriel, you talk a lot about the quality control of gas with detection in nuclear medicine. I got a question about when you perform this calibration or the QC, do you do in-house calibration of your dose meter, or you send it out to the standard lab to do it?
Well, I have to say that in our local area, we actually do it in-house. We have the equipment and we have the expertise to do it in-house. As I did indicate, I do understand that in many instances they have to send it out. They have perhaps neither the time nor the expertise or the equipment, and that works very well as well. The important thing is, of course, is that it's done, it's documented appropriately, and then, as people have already alluded to, if it's not meeting standards, that we do something about it.
All right, thank you, Terry. And the next question, I have a couple questions for Kitawatt, because your topic, people just ask many questions. The first one is, during the lutetium therapy, is the nuclear medicine physician overseeing the patient or the radiation therapy physician in your case?
Yeah, so basically for the theranostic during the treatment, so nuclear medicine physician is the person who take care of the patients, right? And the patient need to stay at the nuclear medicine department. So this is the basic concept.
All right. So the next one is this is the technical question. When giving the treatment doses in your country, which is my country, you use dual nuclear medicine radiographers, check on the dose and administer, or you use single nuclear medicine radiographer?
Well, basically, in order for the lutetium 177, the treatment, so not only for the radiographer take care of the patients, so we have the nurse or nuclear medicine physician, and for the best practice, it would be great if you have like the second radiographer to check the administer activity. This is the basic concept for the nuclear medicine. The patient should be receive the right dose, the right administer, right? So in order to to obtain the most benefit of the treatment, this is the best practice should be done.
All right, and the next one is how long after the theranostic treatment are you waiting for to get the image from the patient?
Right, that's good question. That's good question. Well, it depends on you would like to do the dosimetry as well or not. But if you just like to confirm that the treatment site is correct about the day to like 24 hour or 48 hour after injection, you do the imaging, that is okay. But if you need to do the dosimetry as well to calculate like the dosimetry for the kidney or for the bone marrow, you need to do the imaging at the first day. So it depends on you would like to do, yes.
All right, great. And I think we have a great program today for the first year celebration. And this highlights the role of the radiographers, that not only we take care of the technical aspect of the service, we also take care of the safety and the quality. So to conclude the program, I would like all the speakers to have the final word about this, just to highlight the role of our profession and what you see in the future and what you're looking for in terms of making the patient journey more satisfactory in terms of quality and safety that we would provide to our patients. Let's start with Patrick. You need to unmute your mic. Okay. Patrick, you need to unmute your microphone again. Sorry.
No problem. Hey, for nuclear medicine, I'd say for us, we're growing. Theranostics in the United States is booming. From us in our field, lutetium is what we're doing. We're doing lutetium dotatate and PMSA at our facility, and you're just going to have to know more and more patient safety. You're going to have to understand more things, and then we're always going to see more people involved. So now you're getting nurses involved and everyone else. So I really think it's just more and more education, more and more quality control. And, the technologist is the front line. We are the front line. We're the face of the franchise. We're the people that the patients see all the time. We're the ones that work with them. So it is really important for us to know everything.
All right. Thank you, Patrick. And now it's your turn, Terry.
Well, thanks, Napapong. I think it's been said a number of times, and Patrick said it again, but we are indeed the last line of defense, I think, for many of our patients. And we are in a unique position in as much as we do a lot of the QC for our equipment and also for our radiopharmaceuticals. And I think that we have to understand the importance of that. We have to have the expertise to do that, whether it takes extra education to do so or whether we put that as part of our basic understanding. But it's just so important to make sure that we do these quality control and quality assurance programs to ensure good patient safety and optimum patient care.
Thank you, Terry. And now, Lucas, it's your turn.
Thank you, Napapong. I think I echo both of what the gentleman said. I think that we're expected to know more and more. And the only way that we are able to do that is by being a team approach. You can't be an expert at everything, but we can be good at everything. So I think what we're going to have is we're going to have champions within the department, leaders within the department. And with those people, we're going to lean on those heavily And we need to understand what's going on at the molecular level, because the physician may never see the patient until it is too late, until we're ready to administer the therapy. So if we catch something that's early on, we need to know what's important, what to look for, and then what we can disregard. And so making sure that the patient is prepared properly and educating the patient that they are in control of their study. We can control a certain part of it, but it's up to them to prepare. It's up for them to avoid some exercises, some carbohydrates. The patient needs to be the one that we focus on, and we need to tell them how important it is and how it's going to reflect in their study. And then it's going to change the care of their treatments. The one thing that I always tell a patient is the diagnostic quality of the study is going to depend on you. Whether you're preparing, whether you're avoiding things, or whether you're doing something, you have to get the investment of the patient. And most of the time, our patients have caregivers. So we need to involve the family. So we are a nuclear medicine family, and we need to make sure everybody understands clearly what the expectations are so we can deliver the best possible care to them.
Oh, thank you so much. And last but not least, we have Kitiwat. What's your thought on this?
Yes. So, well, in nuclear medicine right now, we are going to the next, exciting future. So the patient safety and the safety of the staff is very important. So I think, so we must concern about this. And I agree with the Lucas. So when I have the experience for the treatment, so not only we involve with the patients, but we also involve with their family. We have to take care them as well. Yeah, this is the as my perspective.
Thank you so much, Kitiwat. And I would like to conclude tonight's exciting program by our president, Donna Newman.
Before I speak, I would like to give our prestigious CEO an opportunity to say a few words. So, Dimitris, would you please speak first, and I will conclude.
Dimitris, you need to unmute your microphone. Dimitris, yes.
Okay.
Yeah.
Okay. Thank you, dear President, dear colleagues. Dear President, 1 year of a successful series of webinar episodes has been completed. It was successfully achieved thanks to the strong will of those who actively have been involved on that. First and foremost, dear colleagues, we have to thank our President, Ms. Donna Newman, for that. Secondly, due to the electronic skills and the devotion of our Director of Education, Dr. Yutapon, who has maintained the electronic platform vivid and functioning during all these webinars. The Vice President of Asia Australasia, Dr. Napapong, has been a successful moderator of all these sessions, 20 sessions now. Director of PR, Mr. Alan Cromb, has ensured the promotion of the webinars in an attractive manner. Finally, but most importantly, all of our members, you, who have actively participated by watching, chatting, asking questions. I want to thank you all for that and to reassure that the educational activities of the ISRT will be continued to disseminate important information amongst radiographers or radiological technologists globally. Thank you all.
Thank you, Dimitris, our CEO. And here comes our President, Don Newman.
I want to echo what our progressive CEO has just said. I thank you for being open to new ideas. I thank you, Napapong, for bringing the idea forward, and for you and Yutapon developing this idea. It has truly been a great year with our 20 webinars, and we have definitely, by the experts around the world, elevated healthcare to everyone around the world. I want to invite everybody to join us in July. In July, we are going to partner with a vendor, and we're going to be talking about radiography and digital radiography with Fuji. And so I ask all of you guys to think about us and tune in to our Facebook Live episodes in July because we will be covering diagnostic radiology, and I think you will be very pleased. I also want to invite all of our members around the world to go to the ISRT website. All of our presentations are housed there under the communication tab. They're there for you to watch, elevate your education, elevate your healthcare in your countries, and please take time to register for the World Congress, which will be held online in August and in Ireland, and on the weekend of the 20th of August. And I want to thank all of these speakers. Your talks were just phenomenal. Being a nuclear medicine technologist, you have just given us the newest, the latest, greatest in our field of nuclear medicine, and show that you have key expertise in our field to help our radiographers around the world use this information to elevate healthcare in their countries. Thank you guys for taking time for our Facebook Live. And I thank you all for joining us. And until next time, we will see you.
All right. Have a nice day, everyone. Goodbye. Okay, thank you, everyone. It was a great program today.
You know, Lucas, Patrick, Terry, phenomenal. I mean, your guys' talks, I've been listening for a full day and a half on Society of Nuclear Medicine. I've heard no speaker better than you guys that you just presented today. Those talks are phenomenal. Thank you.